Good afternoon. I'm Bethany Saxon, the Director of Communications for the Center for Public Health Law Research at Temple University. Thank you for joining us for the fourth webinar in our Exploring Policy Surveillance webinar series. I'd like to go through just a few housekeeping notes before we begin. Our presenters today will spend some time at the end of the webinar answering questions. Please feel free to send questions as you may think of them throughout the webinar using the Q&A box. To submit a question, open the Q&A panel using the ellipsis button on the bottom of your screen and select Q&A. Once the panel is open, select All Panelists. You may then type your question and click Send. Our moderator today is Heidi Grunwald. Heidi is the co-director here at the Center for Public Health Law Research and is the director of the Institute for Survey Research, also here at Temple University. Heidi, I'll now hand this over to you.
Bethany, and thanks to everyone who joined us this afternoon. Throughout this series, we've heard many examples of how policy surveillance and legal data are being used to create and advance policy. But all of these stories start with data and evaluation. Our panelists today actively create legal data and use policy surveillance to advance our understanding of the impact of laws and policies on health, well-being, and equity, whether it is through the lens of maternal and infant health or pain management. With that, I'd like to introduce our three panelists. Our first presenter today is Dr. Erin Gilson. Dr. Gilson is a health policy research scientist and senior scientist at the Sonderegger Research Center at the University of Wisconsin-Madison School of Pharmacy. Our second presenter joins us from Emory University, Dr. Kelli Komro. Dr. Komro is a professor of behavioral sciences and health education and director at large at the RISE Center for Reproductive Health Research in the Southeast. Our third and final presenter today is Dr. Sue Thomas. Dr. Thomas is a senior research scientist at PIRE and director of PIRE-Santa Cruz. I would now like to welcome Dr. Erin Gilson.
Thank you, Heidi, and welcome everybody. The project that I'm going to be discussing today deals with the healthcare issue of pain management. And I hope it goes without saying that there are many therapeutic modalities that can be used to relieve pain, and including both pharmacologic and non-pharmacologic methods, as part of an overall integrated treatment approach. But when dealing with opioid analgesics and other controlled substances, they have a medical use and an abuse liability. And practitioners are expected to provide these medications without contributing to abuse, addiction, overdose, and death, things that we're hearing a lot about in the media and in professional circles. And not only are they expected to reduce this for their patients, but also for the general public? And this is a daunting task. So practitioners need to understand the laws governing their practice so that they can better adhere to what the laws say about the clinical use of prescription-controlled substances if they so choose to use them in their practice. Because, of course, nonconformity to legal requirements can have legal ramifications. And this is the context that I use to create this policy surveillance project that I'll be describing today. In all, we analyze state-level statutes, regulations, and other regulatory policies that govern chronic pain treatment. And that includes chronic cancer pain, non-cancer pain, palliative care, and end-of-life care. And before I go any farther, I thought I just mentioned that statutes and regulations have the force of law. They're codified, whereas the kind of guidelines and policy statements that I might be addressing today are offered by healthcare regulatory boards to provide guidance to their licensees about how to participate in certain healthcare treatments. This is a legal content review that's based only on observable features, which means that the intent of the policy, although I might know about it, doesn't factor in. It's the language that's contained in the policy. We evaluated policies in all 50 states and the District of Columbia, and when we collected the policy information, the policies were effective through December 31st, 2017. This was a targeted analysis that focused only on the the policies before you. The statutes and regulations and governing controlled substances, medical practice, osteopathic practice, and pharmacy practice, as well as the guidelines for medical boards, osteopathic boards, and pharmacy boards. And because practice standards for healthcare facilities and prescription monitoring programs perhaps fall outside of the types of policies that I've already indicated, we did a broad-based search to find out just where the states housed those healthcare facility policies and the prescription monitoring program policies, just so we were sure that we wouldn't overlook anything. The process for policy surveillance is a lot more involved than the 7 bullets might suggest. In fact, it took 6 months of 100% effort for 2 people to accomplish these and a myriad of other activities that were involved in doing this policy surveillance project. And just for example, a requirement of policy surveillance is redundant coding, which means at least 2 people independently read all the policies that are identified through keyword searches to determine what's relevant, and then meet to discuss them and calculate divergence rates based on the level of agreement on their interpretation of those. It takes a lot of time. And then that's only analyzing the policies. Then that policy language had to be entered into a legal text analysis platform. And we also create master sheets and a number of other law atlas resources that are required to provide an understanding of just what policies are out there and the processes that are used to identify them, review them, and then post them. So it's a completely transparent method that's used for this process. Coding questions are used in all policy surveillance, and I'll get to the coding questions that I used in the next slide. But I want to, policy coding questions are used to kind of guide the type of policy language that's going to be identified within your policy surveillance project. So I wanted to give you an idea of the model policies that informed the coding questions that I used for this project. And you'll see that the model policies are those that are developed by kind of the overarching umbrella organizations for the types of statutes and regulations that I looked at. And you'll also notice that I used 2 model prescription drug monitoring act, just to kind of see what the consensus was among them, as well as 3 sources for the kind of coding questions that have their origins perhaps in federal controlled substances statutes and regulations. As the models change, it's important for the coding questions to follow suit, and I understand that, but I thought it would be good to develop those coding questions based on currently accepted standards, and then have the opportunity to update those coding questions as those standards might change to allow for a fluid analysis. So these are the coding questions for the first domain that I used. Overall, there were 21 parent coding questions that you'll see. And what that means is these are the overarching questions, and then there are some child questions, which is the term of reference used for sub-questions within some of these principal questions. And so the domain 1 is policy definition. So does the practice of medicine include the treatment of pain? What's the definition of addiction that's used within statutes and regulations? What's the maximum amount or validity period duration of a prescription? And then how is unprofessional conduct defined? Does it include a concept of excessive prescribing? And then is that concept defined? Domain 2 is really an attempt to establish a context for pain treatment. So is there a recognition that there is a need for states to reduce harms from controlled substances while maintaining patient care? Are there standards for the Healthcare Regulatory Board that governs healthcare practice to judge the validity of pain treatment, and just what is the standard for that? Are there educational courses for practitioners and for pharmacists about providing medications for pain treatment? And what are the methods for healthcare facilities to improve pain treatment? The third domain are really practitioner expectations for pain treatment. If a practitioner does determine that pain management is justifiable and has a good risk-benefit ratio, then what are the things that practitioner should think about? Is there a need for integrative pain care, more than just controlled substances or more than just opioid analgesics? Does it involve individualized care, which is targeted to the characteristics that are unique to the individual being treated at that time? Is there a determination of patient functioning levels as well as pain levels in determining outcomes of treatment? Something that's gaining momentum but hasn't been addressed prevalently is the use of patient input in determining treatment, to guide treatment. Is the patient part of a shared decision-making process with the practitioner? And then a benefit and risk assessment, not only before initiating pain treatment, but throughout the treatment timeline. These are all important considerations that practitioners should know about if their state's laws or guidelines provide recommendations or requirements for that. And then domain 4 relates to PMP related content. Most states, all but one in the US, have a prescription drug monitoring program. So what is the time frame for the dispensing data to be submitted? It used to be weeks or months, and now it can be even real time or one day lag, so that when a practitioner checks a prescription drug monitoring program, he or she can be relatively assured that that information is current. Does the PMP share data? Is it authorized to share data with other states? Are practitioners required to register with the PMP or to check the PMP before initially prescribing a controlled substances? Like in the second domain, is there a teaching requirement, an educational component of the prescription monitoring program, so that practitioners and the pharmacists know their role, know how to use the PMP, not only to gather data, but to interpret that data so that they can use it for basing clinical decisions on further treatment? And then does the PMP require a review of the information contained in that database to identify inappropriate use of monitored medications? And then what do they do with that information once they have it? So this is the interface on Law Atlas. If you go to my database on state laws and other regulatory policies related to pain care, and you'll see that the coding questions are on the left side of the screen, and you can. Oh, and I also want to point out that there's some important resources, again, to get to the transparency of this data process. You'll notice in the middle to right upper hand corner, there are data, code books, protocols, and summary reports, which are really meant to describe the process and the rationale for the coding questions that are used, especially the research protocol. So to give you an example, if you are interested in the number of states in which the PMP is authorized to share data with other states, you can click on yes, and you'll see the visualization before you. Again, this is only relevant for policies up until December 31st, 2017. But it still presents that information. And I also want to caution that this only identifies states that authorize data sharing, PMP data sharing, through law, either statutes or regulations. But some states can authorize that through other mechanisms. And if it's not contained in law, they may authorize it through other means. So there might be more representation than this map suggests about PMP data sharing, but these are the states with laws that authorize it. And then what's nice, in addition to this visual representation, if I were to click, say, on Wisconsin, where I'm from, it shows the date information of that provision, as well as the language from the specific policy that allows that authorization. So it's really a good database to understand the specifics of the policy information that you're looking for. And again, this is no different from any of the other policy surveillance databases that are contained on Law Atlas. They all have that capability. So the data collection and reporting from the policy surveillance project then results in a research protocol, which is a very thorough description of the rationale and the coding questions that are used for this policy surveillance. This particular research protocol is 23 pages because there are a number of coding questions. So it defines particular aspects of those coding questions. What is a practitioner, for example? The types of terms that are used for addiction. So each coding question defines the terms within those questions to provide you an understanding of where we're coming from in terms of analyzing those data. So the policy surveillance data from that mapping that I just showed you allows the capacity to summarize and then visually display data in various ways, like this simple tabular representation, for example, to provide a clear idea about the ways in which a state's policies could be improved. So it doesn't only provide information to practitioners who are governed by those policies, but that might be of interest to policymakers also, who would like to understand where their policies fall in relation to other states. And so looking at this text box, for example, it shows the three areas that are not represented by state laws, such as requirement to check before initially prescribing, training practitioners, and identifying inappropriate medication use or potentially inappropriate medication use. So it shows that if there is an interest in providing these resources to practitioners, then the statutes or regulations would need to be modified to do that. And I think this is especially important for the teaching component, because the more I engage with practitioners around prescription drug monitoring programs, the more evident it is that it's important for them to have an understanding of what the expectation is for their use and how to best use that to not only identify potentially inappropriate medication use, but to inform other clinical decision making. This policy research was then used by the American Cancer Society to develop a report. It's a brief section of the report. This is a long report that addresses various aspects of pain care. But they included a map that shows states in which there's an above 80% match of state laws to model law or model policy, and then states that have a 51 to 80% match, and then below 50% match. So it does, it's a good visual representation to show just where states fall in terms of how their current policies mirror the models that can be used to help guide those policies. And I also want to make it clear that this doesn't mean, this doesn't in any way represent the extent of compliance of practitioners to the policies in their state. That's a completely different question. This is only how the policies reflect the models on which they're derived often. And the ACS also developed these very easy to use policy reports for each state that kind of show where they fall and kind of what domain of policy analysis went into the code that the extent of correspondence code that they were given, either red, green, or yellow. Easy to use, easy to understand. So when I was asked to present, I was also asked to discuss challenges of policy surveillance. Although policy surveillance is a gold standard for legal research, there are a number of things that need to be considered when thinking about policy surveillance. One is the amount of resources. And this is the number of people who need to be involved, the number of researchers who collect and analyze the policies, the authorities that you might have to call on in order to give guidance about what policies are out there or the interpretation of policies, the amount of time that it takes to identify other policy analyses that might be out there that might not be policy surveillance, but might provide some quick and dirty policy and analysis results that you can then compare your findings to. And also what's time intensive is the policy review process, the data entry, the development of the master sheet for every state and the research protocol. The results also outdate quickly. And of course, outdated policy results is not novel to policy surveillance. It just means that because it takes more time to determine the results or to finalize the results, there is more of a lag in when those results are presented. So a program of research for policy surveillance is necessary. And then the future of policy surveillance, ironically, really depends upon how we can address those resources. And the future of policy surveillance, I was also asked to, I think this is the type of thing we need to, people need to understand Law Atlas and what's contained on them and the wealth of information that's on that website. If we could show that this type of data can actually influence policy decisions, that would be fine. Finding funding is a struggle, but perhaps there can be funding that's devoted to policy surveillance because it is the gold standard, and that's something that we should promote. And then links to quantitative outcomes using longitudinal policy data. This is only a descriptive analysis, as you could tell, but I believe that Kelli and Sue, who will follow me, are discussing projects that link policy data to outcomes. So with this, I'll transition to Kelli Komro's work on economic security policy, and thank you.
Kelli, you can go ahead.
Okay, great. Thank you. Unfortunately, it doesn't seem like I have control yet of the slides.
Here, hold on. Let me.
Looks like I still have control.
Okay, hold on just a second. There we go. Kelli, I'm going to pass it back to you.
Okay, it doesn't seem like I have control, but I can start talking.
Okay, and I can switch your slides for you.
Oh, I wonder why it's not working.
I don't know.
So thank you, Dr. Gilson. That was an excellent example of all the detail and work that goes into the actual policy surveillance piece. And I'm going to briefly talk about the policy surveillance piece in my talk today, but I am shifting and really going to provide examples of how we then use the data from the policy surveillance to examine the health effects of policies. And the project that I'll be talking about today is really focused on looking at, I hope you guys are not hearing all the sirens that are outside. But anyways, they'll be gone soon. The project that I'm talking about today is a project that's looking at 4 different policies, state-level policies that affect family economic security, and then the project is focused around looking at the health effects of those state-level policies. This is great. I like to just start with telling people who I am and how I got to be doing this this work. For the majority of my career, I was actually involved in partnering with communities and conducting community randomized trials where I would be working with families, schools, and communities to implement programs and policies at the family, school, and community level to improve child and adolescent health outcomes. From those experiences, those many years of doing that research, I partnered with communities in inner city neighborhoods, in socioeconomically depressed rural communities. One partnership was with a Native American community in rural areas. From that experience of working with families and schools and communities, I really, really struck me the importance of the social determinants of health as clear drivers of health inequities. And so I decided I really wanted to think through how I could focus my research on examining the social determinants, but not just examining the causes of health inequities. I am interested in interventions to improve conditions. And so as I come to this field of looking at the importance of policies, I come from the perspective of an interventionist, right? What policies can we use to improve the conditions that people are living in? And so obviously I just put up here the graphic, the figure from the World Health Organization's Commission on Social Determinants of Health, which is really the overarching framework that is driving this research agenda. Next slide, please. So I am going to present just briefly a series of 3 papers from this project. I should stop and say this project has been a collaboration with the law team at the Temple Center for Public Health Law Research, and really grew out of their large program that was funded by the Robert Wood Johnson Foundation. And we received funding to actually start this line of research, to really what I consider the pilot work that then enabled us to get an R01 funded by the National Institutes on Minority Health and Health Disparities. In this study, then, we are looking at 4 different state-level policies that influence family economic security, and looking, as I said, the effects on infant and child health disparities. Today I'm going to give the example from 3 studies that we have conducted looking at state-level earned income tax credits. The people may or may not be familiar with this. There's a federal earned income tax credit that is designed to supplement income of low-wage workers, in particular those families with children. It does this by reducing their tax burden while encouraging the recipients to work. And it's administered through the tax filing process. The federal EITC has been praised as the largest and one of the most effective anti-poverty programs in the U.S. And if I don't know if anyone has seen, there's an important recent publication from the National Academies of Sciences that list the EITC, the federal EITC, as a key policy to reduce child poverty. Next slide. So this type of research, I always, it's exciting and it's really multidisciplinary, right? Because it requires this partnership between lawyers who understand the law and are important partners to help us read the law, and then we have the public health folks, which I'm a public health folk, the social behavioral sciences, epidemiology, and statistics are represented in our team, and then also, of course, the importance of the field of economics. So we're lucky to have an economist that's part of our team and helping also to understand these economic policies. Next slide. This is a key resource for anyone who is interested in conducting this type of policy research. Alex Wagner and Scott Burris, editors of this book, where they have put together really in-depth look at both theories to guide this type of research and then the methods to conduct this research. Next slide. This is a diagram on the right here from one of the chapters on the process of coding the laws. And this was, Dr. Gilson gave an excellent example, a detailed example of that process. I just wanted to say here that our public health team works very collaboratively with the lawyers within the Center for Public Health Law Research to come up, and it's a very step-by-step iterative process where it's the public health scientist. We come with the policies that we're interested in, and after conducting a really rigorous review of the literature, and in our case, because these are family economic security policies, it's not only what has been looked at within public health, if there's any prior research on health effects, but also importantly looking into the economic research. And from that process, we come up with what we think are key components of the law, and then share that with our law colleagues, and then they start the process of looking at a couple of states, the actual legal text, and then we come back together, series of meetings, we develop the code book of what we think are the important dimensions of the laws, and so on. And then we go through the rigorous process of the legal coding and the double coding. And then we receive, after that rigorous process conducted by the lawyers, a nice data set where then we are linking it to the health outcome data sets to be able to do this type of research. Next slide, please. This is our conceptual model for this project, which is based on the World Health Organization Social Determinants of Health framework. And in the studies that I'm going to summarize today, we're looking at the effects of state-level earned income tax credits on birth outcomes, the low birth weight, and preterm birth. Next slide, please. So our first paper in this area was where we looking at infant health outcomes. I think let's go to the next slide. It goes a little bit more detail. Yeah. So we chose to look at state level policies because we have this experimenting society, right? We have great variability in state laws, not only across time within a state, but between the states. So this makes it feasible for us to conduct very strong quasi-experimental and longitudinal studies where we have the treated populations within a state over time, so treated and untreated within a state, and then we have the treated states that have a certain policy and the untreated control states. So this makes for us to be able to do these really rigorous studies. We also, an important contribution that we've made to this literature is that we are getting into the details of the law so that we are actually able to identify key components of the laws and categorize states in what we term as the generosity of their state EITC laws. Next slide. So if you look first on the bottom of the slides where I'm showing the categories that how we categorize the states and as far as their generosity in earned income tax credit. So we, this study, we looked at a 20-year period from 1994 to 2013 where we had lots of changes. I think we had about, let me just see, we had about 36 changes in laws during that 20-year period. We had 34 shifts in categories, actually. So this is how we decided to categorize states. So we have the states that had no state level EITC, and then there were two really important dimensions that we found from doing the legal research. One is a dimension of refundability. So there are some states that have a state earned income tax credit which gives a tax credit but does not provide a check if you go beyond, if your tax credit exceeds what you owe in taxes. So those are non-refundable. Then there are states, as the federal EIT has, that are refundable, where if your tax credit exceeds the taxes owed, the family actually receives a check. So we had that important dimension of refundability, and then we had the dimension of actually how large the tax credit was. And most state EITCs are a percent of the federal. So we put the states into these categories of less than 10% of the federal amount to 10% or more, and then the refundability. Next slide. This is a map of the U.S. showing from the period of our study, which was the 20-year period, showing you just the changes from the first year to the last. But as I said, we did observe actual 34 shifts in categories across states and time. Next slide. So then we linked our categorical EITC data with birth certificate data, which is an excellent data source that's reliable and valid across states and over time. Also, I should just back up. We are interested in looking at birth outcomes because they're an outcome that's so sensitive to income, much higher rates of low birth weight babies and infant mortality among low-income families. So it's a really sensitive health outcome, and the data is available to do these types of analysis. So this is the table of outcomes. So if you look, the three columns are three separate outcomes: birth weight in grams, percent low birth weight babies, and then gestation weeks. And so if you look at the first column, the each is compared to states with no state EITC. So you see that if you look at that first column, the babies born to women in states with a low EITC and no refund, babies on average are 9.4 grams larger compared to a period in a state with no EITC. So you see that the effect tends to grow in size with the generosity of the EITC. So babies born in states with a high EITC that is refundable are on average 27 grams larger. And then you see a similar story when we're looking at the percent of low birth weight babies is reduced as the generosity of the state level EITC increases. And somewhat similar with the gestation weeks. And next slide. We also did an additional analysis looking to see if the effects were similar across how small the babies were. So this is the birth weight quintile you see on the bottom. So the smallest babies are on the left. You see and then each line represents a different level of the state EITC. So first of all, you do see that the beneficial effect across the birth weight, and you see, the similar that there's a positive effect for all states that have an EITC, but then you see the larger effect. Similar to what I just presented, the largest effects are among the states, the top line, that have the high EITC with a refund. And importantly, what this graph is showing is that we are actually, even though there is an effect across how the birth weight of the baby, you see the largest effects among the smallest babies, which is an important finding. Next slide. So this is just a summary of what I said. The results in the table that I presented were the percentage point reductions. If you transfer that to an effect size, or just a percent reduction, it ranged from 4 to 11% of reductions in the probability of low birth weight. And then we convert that to actually how many fewer babies born low birth weight every year among women. Oh, I think I forgot to mention this important caveat. Well, we always select on the sample that would be that is most likely to receive the earned income tax credit. So the whole study was focused on women with a high school education or less. I apologize for not mentioning that detail earlier. And then we just translated that for Georgia because people are interested. States often approach us to see if we can give them the estimate of the policy effect for individual states. Next slide. And then quickly, just two additional analyses that we have conducted that's very similar to the previous one. In this paper, we find it to be very powerful to present the effects of case studies. And so we noticed when we looked at the states, all the states, that Washington, D.C. was actually a very unique place where they actually had 4 pretty significant changes in their EITC over time. So we thought it would make for an interesting case study. And also Washington, D.C. has a high percent of low-income families, so an important case study. Next slide. So this is just a diagram showing the changes in the EITC over from 1990 to 2015, the study period. So you see that in 2000, DC initiated an EITC at 10% of the federal, and a year later, they increased that to 25%. 4 years later, they increased it to 35%, and then in 2008 to 40%. And these are fully refundable. Next slide. And this is the outcome of that analysis, where you see that we found a reduction in the percent of low birth weight babies that followed the changes in the EITC. So a very powerful picture of the effects of EITC in Washington, D.C. Next slide. And a summary of those results, when you look at the from going from no EITC to the max that they had, 40% tax credit, we found an overall 40% decrease in low birth weight births from the baseline period. Next slide. And then our third and final papers in this series was expanding, adding a dimension to our original EITC paper, where we felt it was important to see if the results of the state level EITCs differed at all by race and ethnicity. Next slide. So we thought this was an important question because African American women are at much higher risk for low birth weight births. So these are some statistics from 2016 showing the percent of women who have low birth weight births. And you see that African American women have nearly 14%, almost double that of white women. And these inequities are caused by a complex set of social factors across the life course, including income inequality. Next slide. And so what we did was we replicated, because in our original paper we just had looked at the entire sample of women, and so in this one we broke it out and looked at African American mothers, Hispanic mothers, and non-Hispanic white mothers. And we found that the African American mothers, that there was a larger percentage point reduction in low birth weight births, because they started out, their mean rate was higher, but when we converted it to a percent reduction, it was actually, we saw the exact same effect across the three groups, which is a good thing that the policy is working similarly across all three groups. And yeah, I think next slide. So that's a series of three papers that we have, three studies that we've conducted on the EITC. This type of research that obviously is so policy relevant is very much appreciated by groups that are educating policymakers and with policymakers. And so it seems like each time we publish one of our papers, it's quickly being used, which it feels good. Obviously, as a scientist, we don't want to do research that is not important. And so these are some examples of the types of, like, how the results of the research has been disseminated. We have a group in Georgia, the Georgia Budget and Policy Institute, one of their main goals, well, they have many goals, but one of their goals is to educate the Georgia policymakers around the earned income tax credit. So they are a group that will take our publications and translate them into policy briefs to educate policymakers. Our results have been summarized on this website called EconoFact, where they put out nice summaries of research results. and there is a group, a national group called the EITC Funders Network, which is also a group that is disseminating our research results. Next slide. And regarding the challenges, I asked Dr. Gilson if I could, when I saw his slides, it was exactly what I was thinking, so I asked if I could copy his slide and just reiterate exactly what he said about the challenges of doing this research. And to me, the importance of funders realizing the importance of this policy research so that we can actually do this rigorous science to look at the health and well-being effects of policies, which just feeds the cycle of policy making, right? We have examples from other fields now, from alcohol control, tobacco control. I think now they're starting the drug control policy surveillance that is having solid funding to continue to update the policy data sets, which just opens up the possibility of doing this really strong science to actually find out the effects. So that, I think that's the just having that the actual, well, we can't do this research without that policy surveillance, so it's just a critical step. And to get funding, as you know, we do with our individual studies, it's just challenging because we want to continue on. We want to continue to do papers, and we want to, obviously, we want the results to be as relevant to what is the current policy environment as possible. So my last slide, just saying that we hope that we're just getting started. We have lots of ideas for additional studies that we will be conducting in the next few months to years. And I thank you very much, and I look forward to our discussion.
Thank you, Kelli. Sue, you can go ahead.
Okay, let me say hi first of all and see if I can work the slides myself before I begin. And no, just like Kelli, I appear not to have that capacity. So we'll just continue on as we have been.
Okay, that's fine.
Okay. I'm going to present today on a project that deals with substance use during pregnancy, alcohol and other drugs. And next slide, please. And this project is a project of a large group of people from the University of California, San Francisco, PIRE, Alcohol Research Group, and San Jose State University. And what the goals of the project are three, and we're still in the middle of this project, but we have quite a bit to report so far. Our first goal is to look at status and trends of state policies targeting alcohol use during pregnancy and drug use during pregnancy, and looking at longitudinal data over time. We're also very interested in outcome data, assessing the effects of state-level policies targeting alcohol and drug use during pregnancy, and we have two measures of this, prenatal care use and birth outcomes. And our last objective, which we're still in the middle of analyzing, is assessing effects of alcohol use or drug use during pregnancy on SES and race. Next slide, please. And the context for this research is, there are really two kinds of context. One is that the current literature on these topics really lacks any kind of quantitative longitudinal data analysis for all the reasons you've just been hearing from the two prior presenters, Erin and Kelli. It's very expensive and very time-consuming, but we had a leg up in doing this work, as I'll explain in a couple of slides. And so we're looking at specifically whether the effects of policies as they were intended and how specific they are, and whether or not they accomplish their purposes. In this case, their purposes are to reduce alcohol use during pregnancy or drug use during pregnancy. And there's really not anything that we have been able to find in the literature that's addressed those in a comprehensive context. And we find that that's really important to our ability to adopt and implement policies to improve public health. Next slide, please. So for this research, I'm going to describe our data. I'm not going to get into lots of specifics because I think we've had quite a bit of that to date in how we do this kind of research. We started with NIAAA's Alcohol Policy Information System, or APIS, and many of you who are listening may be familiar with APIS, and in a little bit I'll show a slide of APIS homepage. And APIS covers alcohol and now cannabis policy topics over time across all 50 states and the District of Columbia. We started with the APIS coverage of what's called now on APIS pregnancy and alcohol, for which there are 6 different policy topics. And those go back to either 1998 or 2003. And the difference between the 2 dates is the policies on APIS that are very regulation dependent versus the policies that aren't. And what that means is if policies have statutes and regulations, it's possible to get statutory data back decades. It is much less possible to get regulatory data. And one of the APIS considerations in both accepting policy topics and then populating those policy topics in the database had to do with regulations. And I'm saying that now because I'll have a great deal more to say about that a little bit later. What we did is we then extended the APIS database on alcohol and pregnancy to cover a period from 1970 to 2016, or 46 years. And the reason for those dates is they cover the entirety of state-level legislation in this area, in this entire policy domain. And so we have that for our legal data. For our outcome data, we look at more than 30 years of alcohol use during pregnancy survey data from the Behavioral Risk Factor Surveillance System, and more than 40 years of data from birth outcomes and prenatal care data from Vital Statistics. And you can see, if you have access to the slides on your computer, just how many cases those are, quite a large number. Next slide, please. And here's the slide I promised on Alcohol Policy Information System for those of you who may not be familiar with it. And right sort of in the middle of the right square are the pregnancy and alcohol data policy topics. And I'll talk a little bit more about those topics later. Next slide, please. Okay, what I want to get into now are the methods that we used for our alcohol data set and then our drug data set. And so we started from APIS data and then added original legal research to those APIS data to go back in time much longer than APIS goes back. And so one of the things I want to say, if you haven't seen these data in APIS, is that APIS will often, when the policy permits, have variables within a policy topic. So, for example, if we're talking about mandatory warning signs in retail establishments that sell alcohol either to take out of the store or alcohol within a restaurant or bar, we'll have a lot of different variables within those policy topics. And this becomes very important and then complex in explaining our longitudinal database. So what we did is we started with those APIS data, and then we took those original statutes and regulations in APIS and went back over time. And the tools we use to do that are something called Heidi Online and something else called Statescape. Many of you will be very familiar with this, others may not be. Heidi Online is a great resource for statutory data going back decades. And the problem with it is that it's not searchable in the way you might search Westlaw or if you use Lexis, the 2 principal online legal databases for statutes and regulations. So using it is wonderful that it exists, quite possible to use, but incredibly time intensive. It has a sort of search function, but not in the way that you're probably thinking of. And then we use a resource called Statescape because when you're doing effective dates research, you need to find out the effective dates of each statute or each regulation. And those differ across states, and they differ sometimes across time. So Statescape gives us some idea of, for each state, when statutes become effective in that state. And although that might sound like a fairly straightforward process, not so much. In my state, it's a little bit easier. My state is California. I'm in Santa Cruz, California, and we have a rule in our state, unless otherwise specified in a statute, our session laws become effective as statutes, as coded statutory law on January 1st of each year. So we kind of know what that is. But most other states are really different. They'll typically, you'll see things like, this will become effective statutorily 30 days after the end of a legislative session. And then so you have to go back and find the end of a legislative session. And anyway, I don't want to get into all the details, but that'll give you a sense of why this research is so time-consuming. Anyway, we took all this data, we coded them, all the statutes and regulations, added them to our spreadsheet, and not just in terms of each statute, but for each policy topic and each variable within each statute in the places where that was relevant. And we did the usual kinds of things that have been discussed so far in this webinar about ensuring inter-rater reliability, 2 separate coders, doing exactly the same thing but independently, making sure that we've got the right data, the right coding, and everything's been entered properly. We also do an additional step following what's done on APIS, the APIS project, and we also compare our data to any available possible secondary sources. In this case, we look toward Guttmacher Institute data. Next slide, please. And so the drug data set, I want to describe this differently, is because one of the things we found out when we first started this project, we were dealing with alcohol only. But in reading every statute that we read in order to code them and include them, what we found is that almost every time the statutes that deal with alcohol deal with drugs as well. And these are legal and illegal drugs or illicit drugs. And that's true for a really high percentage of the time, but not the total percentage of the time. So we realized rather quickly that we could include in our analyses information about drugs with what we thought at the time would be very little additional research. So what we did is we replicated our original data on alcohol and took all of that information, all of those data that dealt with drugs as well, and then started the process all over again to find anything that was separate, that was drug only. And what you see in this slide really is what I just told you, is we did the whole thing all over again but with drugs. And it took a little bit longer than we thought in all. Using 2 legal research experts, we took the better part of 2 years, I want to say, not straight through those entire 2 years, but we did all the alcohol stuff over several months and then had a little break while we collected, while we were able to get additional money to do the drug data set, and did that. It took almost 2 years, so it's really time intensive when you're doing this longitudinal work. Next slide, please. So the data gathering challenges I wanted to describe a bit differently. A lot of what was said about the challenges of this kind of research is absolutely true. There's another layer when you do the longitudinal stuff. One of the things I found is we decided to work in spreadsheets because we really didn't have the grant money to create a brand new database just for this project and get and pay for the kind of skills to do that well. And we knew a lot about this because 2 of the people on this project, myself included, are APIS staff members doing this work for APIS, so we're real clear about what it takes to build an adequate database for these kinds of research projects. And the reason I say databases would be, having a database to do longitudinal research would be so important is because we ended up with a overall giant spreadsheet that had something like more than 2,500 rows and like 90 columns. That's really hard to work with and to ensure quality control. So that's one of the things I think we need to think of as when we talk about the future of this kind of research, of what we need to build into our projects to make them doable and to make them as reliable as possible to do. Another real big challenge is longitudinal data for statutes, as I said, with Hein Online is possible, time-consuming but absolutely possible, and not too much of a problem. When you're doing it for regulations, it's a real problem. There's no central repository of regulatory data over time that we have ever found. Some states keep data, some states don't. So we went through as far as we could using Westlaw. We went back and tried to track those regulations individually by state. Sometimes we do massive online searches. Occasionally we call states. Occasionally we get clerks from state houses who are really angry with us. We did as much as we possibly could. And even so, I think we still had 2 or 3 missing data points in the data set. So that's a problem depending on how long you want to go back. Before about 2003, it starts getting harder and harder. Then there are 3 other things that people need to be aware of when doing longitudinal data gathering for these kind of data. And overall, there are recodifications, comprehensive session laws, and lack of redlining in session laws. And what that means really is when you're talking about recodifications, occasionally a state will go back and try to resystematize its entire, let's say, alcohol policy codes. And so they'll renumber everything. They're trying to make them more consistent as they're adding things year by year, and it starts getting a little bit unwieldy. And so you have to go back and you have to find out what all the original stuff was, all the original numbers, and compare them to the recods and figure out where your statutory or regulatory information fits in. That's, again, really possible, but really time-consuming. And the people who are doing it, the researchers who are doing it, have to be very well trained to know what they're doing. Same thing with comprehensive session laws. We've got, sometimes you'll see a session law that makes changes to an ABC code, but they don't tell you anything about it other than we're inserting this sentence. And so we have to go back over time and compare session law after session law after session law to find where that sentence even originated, should fit into what was the original information. Possible, we did it, but really you need very well-trained people spending a lot of time to do it. The third part is what we call lack of redlining. There are some states, and I'm thinking of Massachusetts in particular, is one of the states for which session laws will contain certain lines of text that are struck and new sentences added, sort of like I was describing. And once again, you kind of have to start from scratch, going back year by year by year to find where this all fits in. So those are the real challenges, all doable, but really you need to build in a lot of time to make sure that these data that you come out with are good data. So that's where staff training comes in, and we find that when we're doing this kind of work, again, we're working based on the APIS standard, and on APIS, there are 4 people on APIS who work extensively as legal research coders, and 3 of them have been with APIS for the entirety of the project, which is 18 years. Our newbie has been there 10 years. So these are people who know how to do this kind of work, and I think the training they get and the fact that year after year they know what they're looking for really helps. And that's what I meant by quality control at the last part of this slide. New slide, please. Oh, I see this is cut off. Well, that's no matter. I will quickly summarize. What this is trying to depict is alcohol use during pregnancy data on APIS and the 6 policy topics. Very quickly, they are mandatory warning signs that you see in restaurants, bars, liquor stores about alcohol use during pregnancy, reporting requirements, which are required, mandated or discretionary reporters to either law enforcement or child protective services for women who are drinking during pregnancy. Priority treatment is getting women into priority treatment for substance abuse quickly for obvious reasons. Limitations on criminal prosecution are when data are reported for data gathering purposes as opposed to referrals to child protective services or law enforcement. There are some states, California is one, that has what's called a limitation on criminal prosecution, so that that information won't be used to prosecute a pregnant woman. The child abuse, child neglect, the legal significance of that is just reporting what's considered in some states, if you're drinking or using drugs during pregnancy, it's considered child abuse, child neglect. Oh, there you go. and civil commitment. There are very few states, about a handful, that seek to civilly commit pregnant women who are using alcohol or drugs during the rest of the duration of their pregnancy. Next slide, please. Okay, so we took all these data and we broke them down by what's fairly typical in the literature on these topics of supportive and punitive policies. Supportive policies are what's right there on your screen, providing intervention, treatment, information to pregnant women who are using. Punitive policies just seek to control women's behavior who are pregnant for the rest of their pregnancy, and there is an array of ways to do this, by the harshest being civil commitment to child welfare proceedings that sometimes can result in existing children who are taken away from pregnant women, or the fetus being taken away from a woman after the fetus is born. New slide, please. Ooh, one more, please. I think we've gone. Okay, great. So that's sort of the lay of the landscape for our data and what we did to get them. And what we're doing as a result of this are several articles that report our findings. And the first one that this slide depicts is going to be the Drug Policy Status and Trends article. And that's the site. Next slide, please. And what we found in looking at these data over time are really interesting things, and things that maybe we wouldn't have expected based on prior research. So what we found, just general overall findings, is the number of states over time with at least one of these policies has dramatically increased since 1970, when policies such as this were introduced. Almost every state today has at least one of these policies, and the most common ones are here mandatory warning signs, reporting requirements, both for data and treatment and for reporting to CPS, and child abuse, child neglect statutes which go along with that reporting requirement. The least common are civil commitment, which I said was the harshest penalty that we presently have. Priority treatment, which is priority treatment to get pregnant women into treatment as soon as possible. Prohibitions on criminal prosecution, and mandatory warning signs, at least with respect to drugs, that is. What we're also finding is that over time, alcohol pregnancy and drug and pregnancy policy requirements are becoming increasingly punitive in one of two ways. Either more punitive statutes are being enacted, or states are mixing what they're doing. They'll have one or two supportive policies and one or two punitive policies. Next slide, please. So I wanted to illustrate this for you visually real quickly. You can see these are the individual policy trends, drug and pregnancy policies by year, by policy topic. Next slide, please. And this is what you see about the policy environments over time. You can see the increase in all policies, but particularly punitive and mixed policies. Next slide, please. So I have a couple of slides here about our findings. This is pertaining to alcohol specifically, because once we found that the alcohol and drug data overlap so much, and we started with the alcohol, we've begun publishing these kinds of outcome data in the alcohol field. So what we found overall is most policies that target alcohol and pregnancy are associated with increased adverse birth outcomes. And I want to highlight that because the intent of the policies, particularly the supportive policies, were to make sure that we increased positive birth outcomes. And looking over time across all these policies and all these variables, that's not what we're finding. And that is, for the most part, not what the literature finds. The existing literature will be mostly qualitative literature. It'll be cross-sectional literature, and even when it's quantitative literature, it'll be, let's say, a year at a time. But looking over time, that's not what we're finding. And I'll talk a little bit more about why we think that is. But what we did find is the work we did by introducing control variables about generally applicable alcohol policies that apply to the entire population, like blood alcohol content laws and related, is those appear to be better at improving birth outcomes, even though they're not specifically targeted to pregnant women who use alcohol and drugs. Next slide, please. So this is just another slide stating those overall conclusions. I know that our time is getting short, so I'm going to just ask for the next slide, please. Why did we find what we think why did we find what we found, or what can we understand about what we found and how much that differs from so much of the research that's out there presently? What appears to be going on, the best we can piece together, is that if you have a state with mixed laws or punitive laws only, pregnant women who are using report a lot of bureaucratic and logistical barriers to getting treatment or to even getting prenatal care. They avoid prenatal care and treatment and substance abuse treatment because of fear of already having harmed their fetus. There is, to some degree, some belief that it's necessary to stop using before going to the doctor. And there's an enormous fear, and we see this over study after study, some of which I've participated in and others of our team have as well. They fear being reported to Child Protective Services, losing children, going to jail, and so therefore, even in states that may have a supportive policy, if they have a punitive policy as well, women are very scared about how the process might work and what might happen to them. And although our data do not allow us to know that this is exactly what's going on, this is the best of our understanding at present. Next slide, please. What I'm showing here is this is a partial list of what we've published on this project, and there are a good many more in process dealing with SES kinds of issues in race. And I wanted to show this in part because one of the things we're doing now is we're applying for funding to be able to disseminate these findings more widely to policymakers. And because it's a controversial area and because our findings are so different from what had been the understanding prior to this, we thought we needed to make a concerted effort to say, here's what we need to understand as we continue to make policy around these areas. What do we need to do to make sure that we're doing a better job than we appear to be doing at present? Next slide, please. And my last 3 slides are just overview things. I wanted to acknowledge our entire policy team. This took a lot of people and a lot of years of work, I believe so far about 5 years overall. And because we had so much data, we also had a very special biostatistician to help us from ARG, Mina Sabariam, who is incredible, as has been everyone on this project. Next slide, please. And our funding so far has come from these sources. Next slide, please. And I just wanted contact information for anyone who wanted additional information. And from there, I'd like to pass it on to Heidi.
Thank you, Sue. Heidi, go ahead.
Well, at this time, we'd like to take some questions. As a reminder, to submit a question, open the Q&A panel using the ellipsis button at the bottom of your screen and select Q&A. Once the panel is open, be sure to select all panelists on the drop-down. You may then type your question and click send. So while we're waiting for some questions to come in, I want to thank our presenters. That was really amazing, so fun and interesting and great for us here at the Center for Public Health Law Research to see all this great policy surveillance work, from Erin's legal data building and ranking and scorecards to Kelli's longitudinal work around income support policies, really starting to inform policy, and then Sue's long-term work on alcohol policies. So thank you to all 3 of you for joining us today. I don't see any immediate questions popping up, but I'd like to sort of start from the challenges, because that seems to be something that all 3 of you talked about. It's resource intensive, meaning funding for people, for the tools that are needed, the time that's needed, finding the outcome data that's appropriate. I guess I pose the question to all 3 of you, where's the low-hanging fruit there, or is there any, in finding solutions to these challenges?
Please.
Oh, go ahead.
Okay. this is Aaron. In reflecting on what Sue had said, I think it's engaging with policymakers. And when you get the interest of policymakers and their awareness of how these data can influence their decision making regarding the types of policies that they put forward, I hope that can serve kind of as a self-sustaining mechanism that will lead to the expectation that that you have a trusted source with valid data that you can go to find out about these issues. And I just reflect back on the University of Wisconsin's history with engagement with the legislature, and that's something that they proffered for a number of years. And I think the availability of empirical data just make that more persuasive.
Sue, did you want to add?
Well, I wanted to ask a question. When you did you mean in terms of legal data or in terms of getting the information out there?
Well, I mean, I think in general, like the whole process here, right? You know how we have to convince the policymakers of the importance of the work. They have to see the work demonstrate meaningful impact as either they're making policy or changing policy. But in the cycle, in the process, it's large teams and interdisciplinary and transdisciplinary teams. It's the legal data building side and waiting for that to happen, and that goes out of date quickly. So I'm just wondering, like, how do we do this? How do we do this science better and faster?
Oh, well, that's interesting, because when we started the APIS project, at this point it would be, the vision for it and convincing NIAAA in particular, that they wanted to fund something this expensive and this ongoing was a pretty heavy lift. But now that we've demonstrated 18 years of this, I'm hoping that people who do this sort of work, such as the people here and on the call, would work with NIH and all of its relevant components to convince them that this kind of work really needs to be funded, because doing it policy by policy or year by year, everyone's pointed out, is really good but not enough. We need the ongoing kind of commitment to these sorts of resources.
So there's a question. Tracy Side says, Monaco is one example of a great policy surveillance platform. Are there any other software programs to consider? Sue's point regarding spreadsheets and databases really rings true.
This is Sue. I don't know of anything else out there, and I know that when we started APIS, we created a custom database that, had it been done, it was done by a staff member with those skills, and that's why we could afford doing it, because it's a very complex database with forms and subforms and over time. And anyway, just learning it takes time as opposed to gathering the data. I don't know of anything else out there, but I know that that would be, to be able to fund, let me put it this way, to be able to get someone to fund a product like you all use that does the longitudinal piece would be incredible. And I don't know what the possibility of funding for that is, but it would be really important.
Right, and I think the distinction needs to be made between a type of database that is an Excel database versus the type of database that are contained on Law Atlas and APIS, which are vastly different. I have a question that I think might benefit the audience. First, I really enjoyed Kelli and Sue's presentations, and am envious in their ability to apply their policy findings to outcome measures. And I'm wondering what their perspective is about what is it about the policy surveillance process that benefits analysis of quantitative data?
Sue or Kelli?
So I'm not sure I'm understanding your question. What?
Well, there's often a schism between policy research and empirical research, but the two of you have blended those. And I'm wondering if it's a characteristic of a policy surveillance approach that allows you to do that. And
well, maybe. So let me just see if I can rephrase this. I think, part of the work that we do here at the center is making sure that the receivers of these empirical legal data have what they need, both in terms of a time marker, whether it's annual, monthly, they have the effective dates, which is really important, which Sue talked about how difficult it can be to find them as you're going back in time. You have the variables, the code books, you have the legal protocols. I'm not sure if anyone looks at those, but, I guess if someone was going to try to replicate one of these data sets, they would be able to do that. Hopefully they would. I don't know. Do you guys have other thoughts as the sort of quantitative receivers of the types of data that Aaron Shop and we here build?
Yeah, well, I mean, it's the longitudinal data sets that are critical for us to be able to do the rigorous science. So it is, so that's even more intensive than just doing sure of what's happening right now, right? Because we are going back over several decades, and the effective date is critical to that. We need to know. That's how we're doing the analysis, because we're doing quasi experiments. What were the outcomes before, pre-law? And how do the outcomes post-law differ? And so, right, that's a really important detail of how we do our research.
And Heidi was getting at kind of the transparency of the methodology, but I would also argue that the policy surveillance process of itself heightens the validity of the policy data and makes it, I think, more useful for this type of research than a quick and dirty policy analysis that doesn't adhere to the rigor that we described in all of our projects. That does result in more valid and reliable policy data.
Definitely, and that's why we embark on these these long-term collaborations with the law team to do this process. And because that came out of my collaborators' experience in doing policy research and knowing that some other sources of policy often have many mistakes in them, right? So it's the importance of going back to the original legal text and going through this process. Definitely.
Yes, and I can add that we at APIS always include secondary sources as part of our QC, and I will echo what Kelli said, that existing sources with not having anything to do with public health law research, but the others out there, either are collected at one point in time and give you no idea when these laws became effective, how long they've been in existence, or are really poorly done. Or a third thing that's not poor but doesn't lend to the kind of detailed analysis we need is they often are what I think of as yes, no, or on-off variables. The policy is there or it's not, but what about all the details of the policies that really critical to understanding how they work on the ground?
Yes.
That's what I think leads to a lot of the validity that you're talking about and credibility.
Yes, one of the challenges is blood pressure with policy surveillance, because I had very many micro-panic moments in comparing my findings to to other more quick and dirty policy reviews and noticing a discrepancy and then scrambling to find out why, and it was invariably because they missed it. So it does point to the benefit of the rigor.
Well, that's also, and I know this is a feature, and a really critical feature of the public health law research team, is getting legally trained people, because unless folks really know how to deal with those statutes and regulations and those session laws, they don't know how to interpret them properly.
Mm-hmm. Yep.
Well, I don't see any other questions, but let me throw one more out there since this is the evaluation webinar in the series. You know, Sue, you didn't speak specifically to your methods, but we know, Kelli, for example, that you have an economist on your team, and so maybe you guys can talk about some of the types of models that you use in the analysis for these, you know, so from difference in difference to discontinuity regression. You know, Kelli, maybe you can talk briefly, and then Sue, I'm not sure if you're the right person on your team to talk about the methods.
Only legal, for me, I have to say only legal methods, but our biostatistician, I know she really struggled because so many of the data we got for outcome measures were available but in the wrong form, and we spent about a year forming the data to get them to be able to use them for what we needed. So, yeah.
Yeah, so we are using the difference in differences modeling, and when we are able to, we even add a component of difference and difference and differences, so that we're comparing the sample that would be most exposed to the policy to those that don't, right? So not only do we have the pre and post law and the intervention states and comparison states in the difference in differences modeling, but then we also would have another comparison of a population, like the low income population that would be targeted by the policy versus a population that's not low income, right? So that's a very typical method we use. The other method, the example that I gave from the Washington, D.C. study, is the interrupted time series analysis, where you are looking at this case of D.C. and the repeated policy changes, but then we also use a comparison. We used a comparison of other states. So those are two typical methods that we use.
Excellent. Thank you for that. All right. Well, I don't see any other questions coming in. So again, thank you all for joining us today. We want to remind you that the slides and a recording of the webinar and others in this series are all available at phlr.org and can be found on the same page where you registered. We also want to encourage you to join us for the last webinar in the series on May 14th. Our presenters will explore the use of policy surveillance for policy making. So many thanks again. Have a great afternoon.
Thank you, Heidi and Bethany.
Thanks.
Thank you all.